the content, we're really excited that both Deepti and David from different continents and different time zones are willing to talk to us about their experiences with tuberculosis. Whatever we do in TB control, TB care, TB prevention, the people that actually are affected by tuberculosis are really at the heart and the center of why we do this work. So it's more than fitting to actually start when we think about a learning network or sharing knowledge towards countries on how to better engage the private sector in TB control, or anything else that we want to improve in TB control. Let's really start listening to the people that have gone through an experience of dealing with tuberculosis in all their ways. So I'm really happy that you're both willing to share your story, and thank you very, very much for being with us today. I would like to introduce Deepti. Deepti Chavan lives in Mumbai in India. She has survived dealing for 6 years with treatment of tuberculosis, and she had one entire lung removed. She looks really healthy and beautiful today, and I'm really happy she's with us. She's an active TB activist in India. She speaks beautifully, and I'm looking forward to hear her talk about her story. So I'd like to hand the floor over to Deepti to start.
Thank you so much, everyone, for taking time out from your busy schedules and to be a part of this webinar. I was 16 when I was first diagnosed with TB. And initially, my doctor just dismissed it, saying that it is just a viral cough, and I was put on treatment for pneumonia. And when I wasn't getting better, that's when they actually gave me a TB test and realized that I have TB. I took medicines for TB for about a year or so, but I wasn't getting well. And what the doctor kept doing was he used to keep on changing medicines week after week after week. If I reacted to certain antibiotic, he would stop that antibiotic, start another one. If that did not suit me, he would put me on some other regime. So it went on for a year, and finally he told my parents that let us get a DST done. And we did not know what DST was. I had TB as a child as well, so we believe that tuberculosis is a disease for which I will have to take medicines for 6 to 8 months, and I'll be fine. So he told us that DST is a test wherein we can find out that which medicines will work on her and which won't. So we were initially surprised as to if this test is available, why didn't the doctor order for it sooner? And why did he wait for a year to actually let us know that, there's a test wherein we can find out which medicines are working? Because as you know, the medicines have severe side effects. My hearing was affected, my vision was affected, I had severe joint pain, I was vomiting all the time. And I always say that, the TB treatment is such that patients often find that dying is easier than completing their treatment. And the doctor said that, it's not, it's very rare that, people don't get well with a certain set of antibiotics. And that's why we need to get the test done. We got the test done. And then when the report came, he told us that I was resistant to most of the TB medications, and that I will need a surgery to get a lobe of my lung removed. We were shocked, surprised, angered, and we didn't know how to react. I was just 17 at that time, and a surgery for TB was never heard of. So we got the surgery done. Despite getting the surgery done, the treatment went on for 4 years, and the doctors then told me that, the medicines aren't working, and the infection has spread to your right lung as well, and we cannot help you. And most of the doctors I went to gave up on me, and they told me that I had 6 months to live, and you basically told my parents that, you should fulfill all your wishes of your daughter and let her die peacefully. And that made me realize that, if doctors have given up on me, and if nobody is ready to help me, it's upon me to help myself. I told myself that no matter what the doctors are saying, no matter what the science says, that I'm going to fight this. I took it upon myself to find a doctor. I wrote emails to random doctors all over the world asking for help. A kind doctor replied back saying that coming to UK and pursuing the treatment would cost you a fortune, and we wouldn't be able to afford it. So he suggested me that I go to Dr. Zarir Udvadia, who practices in Mumbai. I went to him, and he also told me that your case is difficult, but we will try. We will try. That those words were something I was waiting to hear from a doctor, because we trust doctors so much. We trust them with our life, and when doctors give up on you, that's when, we feel that we are losing this battle. But with him, I realized that, there are doctors who won't give up on the patient as long as the patient is also fighting with them. And I started my treatment under him, and I needed another surgery. The surgeon also told me that, there's just 1% chance of survival. Do you really want to get the surgery done? And by that time, I was 28 kgs. I was completely bedridden. I was just like a vegetable. And my mom used to bathe me, feed me. And, TB patients usually have this strong guilt that, and they have this fear of maybe infecting their loved ones, and we self-stigmatize ourselves so much. And I just want everything to be, just go back to normal. And I couldn't see my parents suffering. So I told the surgeon that I want to get the surgery done, no matter what the outcome is. If I die, let it be, but I do not want to lead a life like this. And that's when I got the surgery done. And that's when, the surgeon, it took, I think about 8 hours for the surgeon to get the surgery done, and the infection has spread everywhere. So he told my parents that I have done the surgery, but I cannot guarantee you the outcome. She may have to stay on ventilators for months, or she may not make it. But to everyone's surprise, I was out of the ICU the next day. And that made me realize that, having seen so much in the 6 years, I decided that if my experience helps someone to, if I can motivate someone to finish their treatment, or if I can be their voice, then what better? I couldn't have asked for more. If God has saved me from so much, it must be for a purpose. And that's why I do what I do. That's why I want to be the voice of TB patients. And that's why I am into TB advocacy.
Thank you so much, Deepti. Is there anyone who has any clarifications or questions in this stage? I don't see anything popping up. I don't see any questions in the chat box either. So maybe, Deepti, thank you. That I'm just stunned for words that dying should be easier than treatment. Can I just give you the platform to keep talking in this stage, and we will see if there are any comments or questions after. So please feel free to keep talking, Deepti.
Okay, so the whole point about us talking about our experience is because we do not want anyone else to suffer the way we did. People are losing their hearing and their vision because of TB medications. And is there a question?
There is a question, but is what about private versus public sector? Did you go to the public sector? If not, why not?
Okay, so initially I was taking treatment in private sector. When the private sector had given up on me, I went to the public sector, but I was, they just dismissed it, saying that, we can't help you, and anyways you are going to die, so there's no point in, continuing the treatment. And I was like, they just told me that you will not make it. So I did go there. And the second reason why I did not feel like going to the private sector, public sector, is because there is no dignity. I mean, when when they say that the treatment in public sector is free, um, we really need to understand that is the treatment really free? Uh, I have seen patients being stigmatized and discriminated against. Like when I went there, and after my visit, someone told, "Please change the sheet." And uh, is there another question?
Yes, please keep talking. I'll collect two
Okay.
more questions, and then when you're done, I'll ask them.
I saw with my own eyes that when the patient was administered medicines, they were asked to stand at a distance, and then the medicines were kept on a chair, and then the patient was asked to come and collect the medicines. So seeing this discriminatory behavior, I thought, was my dignity, my self-respect is more important to me than anything else, right? I got TB because I breathed. I did not do anything to actually get this disease, right? So there is no point in people treating us like criminals. We haven't done anything. Just because my immunity was low, I got TB. So when you are treated in a certain way, we do not want to be treated that way.
Thank you. So the two extra questions were, how many private practitioners or private physicians have you visited? And did you get any gene expert to test for MDR-TB?
Okay, so I think I went to about 6 to 7 private physicians, and I took treatment from the year 99 to 2005. So I'm not really sure if Gene Expert was available back then.
Right, and so how long, the question was, what is the delay in the diagnosis? So how long did it take you? You told me that you had TB as a child already, and then
okay,
in 2000.
Yeah, so when I was a kid, my TB was cured in 6 to 8 months of treatment. Then I got TB again when I was 16. So for a year or so, the doctor did not ask me to get a DST done. So delayed diagnosis, I think it took about a year or so for me to get diagnosed with MDR TB.
Okay, thank you very much. I'm sure there's one more question. Did you face any stigma from friends and surrounding community when they found out you had TB by the age of 17?
Okay, so I was always open about the fact that I had TB. So my friends, my family, my extended family, everyone knew that I had TB. And surprisingly, my friends and family were supportive. But the problem was with neighbors and with extended family. So that's when I thought that, I was in isolation for a longer period of time. And when I was finally non-infectious was when I started going out of the house. And I still remember this incident distinctly, when I had gone for a function and everyone looked at me as if I had committed some crime and I shouldn't be here. I shouldn't be at the function, and I should be locked in my house. And everyone started looking at me in a way that made me feel uncomfortable. And that's when I decided that I am not going to, go out of the house again.
Thank you, Deepti. One more question. Can you inform us more about whether the private doctors were aware of protocols to diagnose TB?
I took my treatment in Mumbai, where we have the best medical care that one can get in India. But surprisingly, many doctors I went to were not aware about the treatment protocol. Like I said, they were just experimenting with drugs. If one drug failed, they would add just another drug, or they would add two more, and they would stop the treatment midway and ask me to get something else. So.
Thank you. Did you pay for any of the medications or the surgery, and was that out of your pocket, or were you covered by insurance?
No. So since I took my treatment in the private sector, I had to pay for my treatment. My father worked in a government. My father was a government servant, so a part of treatment was sponsored by his office, but other expenses was we had to take personal loans and sell off jewelry, and that's how we managed to pay for the treatment.
Excellent. Thank you for all the questions from the participants, and thank you for answering all of them, Deepti. Deepti, do you want to I think we have another 5 minutes if you would have a few more things that you had prepared to say related to the things we talked about beforehand. Would you like to say a few more things?
Yeah, so basically one question that you asked me was what needs to change in TB care. So I want to say that we need to make sure that those affected are at the center of the TB response. I mean, one size fits all cannot be the norm in TB care because, like I said, it's a very complex disease. Like all our doctors who are joining us in this webinar, and they know how complex this disease is. The treatment is not easy. So, and also there are so many socio-economic factors involved. Like a superstar who said he is a TB survivor will not have the same problems say I had, or maybe someone from a poorer family would not have the same problem. So if when we say that the treatment is free, we'll give you the medicines, but is the treatment really free? What about the long waiting hours? What about the discriminatory behavior that is meted out to patients? And what about sometimes there are no medicines available? Like I counsel patients on a daily basis. I know there are so many incidents of stockouts. There's no proper counseling. How do patients know what they have to, like TB medications, like I said, are so difficult. The treatment is so difficult that there are so many problems and so many people are facing so many problems, but there is no one to address those problems. All every government program, every TB program just want patients to take medicines, and once they are cured, there's just one number. They'll just pick that number saying that this patient was cured, but what happens to the patient afterwards, no one really talks about it. Also, the onus of is on the patients to get cured, right? The responsibility lies with the patient. If God forbid the patient doesn't take the medication, they are labeled as defaulters and lost to follow up. But we need to understand that if someone is leaving the treatment, everyone wants to get cured. Who doesn't want to get cured? If the medicines are not safe, if the medicines have severe side effects, then what's the point in telling patients to complete the treatment? And I want to cite the example of bedaquiline. Bedaquiline is a safer drug which is now available, and there are like strict guidelines for it, that for example in India, certain people living in certain areas are not receiving bedaquiline. I mean, when you form such policies and when you make such guidelines, I don't know what we are even thinking. Are we telling the patients that people living in certain areas, their lives are not worth it? Or uh, I really don't understand how all this works. The onus always lies with the patient to complete the treatment. But when decisions are formed, when policies are made, those patients are conveniently left out of the discussion. And people, like, they are just, we need a seat at the table, because we know what will work and what won't work. And I always say this, that if you really want to find out what's not working in the program and what the problems are, just gather a room full of people who are affected by the disease, and at the end of the discussion you will come up with the problems, and not just the problems, they'll also tell you what the solutions are, because we exactly know what works for us and what doesn't.
Thank you, Deepti. Some really important points that I think we should be repeating, and I'm thinking of Nandita saying on behalf of all TB activists and TB survivors during the union conference also, that no action, or what, sorry, now I lost my quote. No, but it was basically saying no action about us without us. And that's exactly your point too. So I'm seeing that we have one more question. I'm just asking if there's anyone else who wants to ask a question to Deepti, please let me know now, because I think we'll be wrapping up with Deepti and moving on to David. The question, Deepti, is what can you suggest about awareness about TB diagnosis? And can you also talk a little bit about the behavior of staff after a diagnosis? Like what kind of counseling was offered?
Okay, so I was offered no counseling. Firstly, because I took treatment in the private sector, and there was no provision of counseling. It was my family who spoke to me about it, and I was totally dependent on internet to get any information I needed. but apparently they say that there is counseling available now. But I was on a mission recently, like I said, like I told you, and there were many counseling posts which were vacant. So, what happens is at when there are nice schemes, there are nice policies, and everything is in place, but on paper. But when it comes to implementation, very little is being done, and people on the ground know what the realities are, and there is so much that is being said that it's done, but on ground it's not being done.
Okay, perfect. And what about the awareness about TB diagnosis? Is there a broader information, not just the counseling, but more in general? Is there any information that you feel should be done, or?
People now I can see there are advertisements or say maybe posters that if you have cough for more than 2 weeks, then you should seek treatment. So now I can see things are happening, but earlier when I was taking treatment, I had no information whatsoever about the disease, and whatever information is available now, I don't think that's enough. We need to really do more, and we not just make people aware about the symptoms of TB, but we should also talk about the stigma that comes with it, and how we shouldn't be discriminating against those who have the disease.
Thank you very much, Deepti. I think you've spoken really well about your story, which is very illustrative of the struggles that people that contract tuberculosis go through. And you've given some really good points about how important it is to listen to survivors of TB control, and in any aspect, whether it is related to the counseling that was not offered, or the drugs that were not given, the diagnosis that was basically bounced from one place to the other and experimental. These are good things to reflect upon as anyone who's listening, and I thank you very much for bringing this forward, and keep on speaking up on behalf of all the TB voices, because you're doing a fabulous job, and I think it's very important to hear your story and to actually hear the pointers that you're putting forward. Can I move on? There, you will get a chance after David has spoken as well to say something else if you want to step in at that point. But right now, I think we'll move on to David.
Yes.
David Mungai from Kenya. He's right now in his Are you in actually the hospital where you're treating?
Yes, yes.
So David has been has had contracted TB while he was on medical training, and went through TB treatment. He will talk about this. He's now a surgeon in the hospital, a private hospital, a teaching hospital, and he's actually also treating TB patients. So he will give us both sides of the coin, but we'll start talking about his story, tuberculosis. Again, as last time, we will take a pause after about 5 minutes, where you will get a chance to ask questions about his personal experience, and then about more what are the lessons learned, or the more general questions he will then go into after that. So please, David, go ahead. We're very happy to have you here.
Thank you, Patra. Thank you, Deepti, for such a deep story, and thank you, everyone, that you are able to join us. So my story begins as an undergraduate student, a third-year medical student, after having a clinical teaching in a surgical ward. Then a few days later, I developed chest pain and some fevers, and I went to the university clinic where I was attended to. And so initially I was put on treatment for pneumonia. And so I took treatment for the first week. Initially there was some improvement. Then the second week, still the fevers were still there, the cough was worsening. Then I went back to the university clinic. And at this point, the medical officer who was there then started thinking this is more than TB. So initially requested a chest x-ray, which showed actually features of TB. Then I was told to produce sputum, and that's when TB was diagnosed. So it was on x-ray and also on producing the cough. So I was started on this journey for TB treatment. And so I was cancelled. I was lucky I was cancelled. And then I was told I'll be on treatment for the next 9 months. 2 months intensive, 8 months, sorry, 2 months intensive, then 6 months of continuation. And after every 1 month, we'd repeat the sputum and check whether it's becoming negative, meaning that I was responding to the treatment. So as a good student and a good patient, I was taking medication. Then after 30 days of the intensive phase, we go back to the clinic and we do the sputum. It was still positive. And the staff there were very encouraging. They said, oh, this happens, you've seen this before, so continue your medication and we'll see how it turns out. So after 60 days, sorry, 2 months, we repeat the sputum, now it's still positive. So at this point at the university clinic, which wasn't a specialist TB clinic really, it was just a general clinic, everyone became worried. And at this point I was told then, I need to be referred to the main teaching and referral hospital in Nairobi. And so I was sent to the largest teaching and referral hospital in Kenya, which luckily enough was also the teaching hospital for the university I was in. So it was easier to be referred. So when I was referred there, I was referred specifically to the TB clinic, and I was to see a chest physician. So I started this journey of being reviewed by a specialist at the teaching hospital. So initially, the first thing that was thought was, as a student, a university student, hadn't been really compliant with medication. So the first thing they did was to put me on dots and see whether I was taking my medication. At the same time, we took sputum. We didn't have gene expert then for microscopy, culture, and sensitivity. And so at this point, I was told the technology then was going to take long. It actually took 90 days for the results to come back. The specialist, after 1 week of seeing my taking of medication, then said, it seems this to be a treatment failure. So an injection was introduced. And this was the beginning of now my tough journey. So we introduced streptomycin on my treatment. And so I continued with streptomycin for 90 days as we were waiting for the results for microscopy, the culture, and sensitivity. And so unfortunately, when the results came back, it was resistant to all the molecules apart from pyrazinamide. And so I was told I have primary MDR TB. It was difficult because I think at this point in our country, we didn't have a clear program and protocol and policy of how to treat MDR. So I was among the first cohort of patients who were diagnosed with MDR. And so now we started writing letter because now I was a medical student. I was doing medication at the university. So all this time the university had taken care of my treatment as a responsibility to the student. And so now we started writing letter to the university so that they could come on board and agree to pay and buy the drugs that are required for the treatment. Lucky enough, the chief university pharmacist, the chief medical officer, and the management agreed that they'll buy the medication for me. And so I started injections for amikacin, which I did for 6 months. Then we repeated sputum at around 2 months after starting the MDR treatment, it was still positive. But lucky enough, by the 6th month, it had turned negative. And then now I continued with this MDR treatment for the rest of my medical school until the last year. So the total treatment for MDR took 24 months, then adding the other few months. So it was 24 months plus something. So it was a long journey, it was difficult, but I'm happy that I had nice support from the university staff at the clinic. I had counseling. The university even went ahead to give me nutritional support and all that. But the biggest challenge came to the general population, especially of the students and the general workers at the hospital. So remember, during class time, I had lost weight significantly. And one of the things that everyone thought is that I was HIV positive. And I even remember initially at the clinic, one of the consultants had insisted that we need to do a ELISA test for HIV, which we did thrice, and it was still negative. At that point, I was feeling really stigmatized. And at some point, I asked that I get reviewed by another specialist, a second opinion sort of. And so the main stigma came, especially from fellow medical students, the general workers who had seen me lose weight and really really deteriorate in terms of my health. But at the TB clinic, and family and friends support was overwhelming. And I'm glad that I was able to be treated and got well. So because of that, I decided that after my medical school, I just fizzle out, go practice my medicine quietly, and just say I was lucky I survived. I never wanted to speak about TB. I never. And one of the nurses at the TB clinic at the referral hospital kept contact. We kept contact for so many years, and he would update me what's happening. And so when I went back to the same teaching hospital for my master's, we reestablished this connection. And she insisted that I'm such a valuable person, I need to come on board and help them speak about TB. So what really got to my heart was when I was told that majority of the cohort of patients I was with during that time for MDR treatment suffered complications from nephrotoxicity, kidney failure, hearing loss, which Deepti was speaking about. And actually we lost some initially. And so for them, I was actually one of the main success stories from the clinic. And they really wanted me to come back and speak about it. And so finally, I agreed. I mean, it was such a difficult decision because I really didn't want anyone to know that I had TB in my life at all. And so one of the NGO, the Center for Health Services, together is Stop TB Partnership Kenya, came looking for me where I work as a surgeon. And they really wanted to share this story. And so this story was shared in one of the dailies in our country. And so I came up, and now I'm working with Stop TB Partnership Kenya as a TB advocate, really with the interest of just speaking to the health workers who are at a higher risk of TB because they're the primary people, primary caregivers. And of course, just encouraging them to come out for screening and seeking treatment as they can. Yes.
Thank you so much, David. It's good to hear your story, and of course we're really happy that you were the success story of the hospital and made it through so well and are here with us today. Can I ask anyone whether you have any questions to David? So I have a question, David. I'm just going to see whether anyone will write anything on the chat function. But so you were treated in it was the public hospital, right? You didn't see any private practitioners.
No. It was a public hospital.
Okay.
Yes.
Is there anyone who wants to ask David any questions? No. Oh yes. Here we go. Is there any routine screening from the staff? That was the first question. And the second question is, thank you for sharing your story. I'm glad you mentioned about not wanting to initially share your story, because for some survivors find that sharing their story is too painful, and we as community need to be respecting that too. But we are certainly grateful to you. Thank you for that comment, and that's definitely very true. We have to respect people's individual choices, and we're very happy that you speak about it. Can you say something about the routine screening of healthcare workers and staff?
Yes. Currently now, the national program has policies for screening and testing of health workers. But like I had mentioned earlier, what I find out that there's a lot of stigma among the health workers. So even with that, not so many people want to come forth and have the screening and testing done. And one of the things is, like I mentioned, the association of TB with HIV. Like someone thinks once you have TB, the next thing is that most likely you have HIV. So a lot of health workers are withholding and just having a backseat. And so those are one of the main reasons why I'm coming forth as a health worker who survived, to just say, indeed, it's possible to have TB without HIV. And indeed, that we appreciate and we know that stigma is high among the health workers. But if we keep on hiding and not speaking about it, then it will be a very difficult fight for ending TB. So yes, there are policies and protocol for that, but still the uptake is not quite good. So we need to work on that.
Very good. There's one more question. In your experience, what is the best way to engage private providers in TB care? Most prefer not to work with national TB programs, but we need to engage them to find and treat the missing people with TB.
Yes, one of the things that the private care providers mention is that the whole program for TB care and management is free. And so if they're going to spend their time, their resources in terms of the personnel they'll use and the resource in the lab they'll use for diagnosing and treatment, then it's a loss to them. So one of the things, and it's in our policy as a country, that we work on something, a form of reimbursement, such that there's a system where they don't need to use their resources to help in treatment and management of TB, but resources from the program. And if they incur resources from their own kitties and all that, they can get a reimbursement. Then this would work. Secondly, is what I've always been saying. I think the perception back then was that TB was a disease of the low socioeconomic status. I'm saying that indeed TB now affects everyone across the socioeconomic divide. So when I'm having my private practice and I'm seeing these middle class and well-off clients, and some who have these symptoms that are suspicious of TB. For example, a cough for more than 2 weeks, a history of significant weight loss, a history of a fever, but I still go ahead and insist on treating pneumonia and non-TB because I don't want to associate TB with this class of patients. So that perception will need to change a bit, and it's not easy. I think we'll have to keep on speaking about this, keep on engaging them, and they need to come on board.
David, two questions. One is a general question that I want Deepti, that is also addressed to Deepti, is if there is one thing that you could, in your opinion, what is the one thing that that we should implement? Like, would it be more mass screening or educating the mass population about TB to reduce the stigma you experience? What would be the one thing? So if you can both think about that, I'm going to ask you a second question, David, that came up. I know we have issues with stigma among healthcare workers, but with your story, we will improve screening and diagnosis of TB amongst healthcare workers. So thank you, they're saying to you, David, for speaking up and bringing that forward. And so stigma, this is our biggest challenge. We really need to urgently address this if we are to end TB. The association with HIV needs to be demystified. So it's again a comment, but maybe David, you can speak to those 2 points about the stigma and also about what, if there's one thing that needs to be done. Mass education is very critical, and is saying there are still too many misconceptions about TB. So with these comments in mind, can you reflect maybe a little bit about stigma around HIV and TB and how the TB stigma piece fits in? And if there's one thing we could do, what would it be?
Thank you very much. I totally agree. I mean, the starting point for me would be the continued mass education, which is very, very important. And it's from that education is where people will understand and do away with this myth and misconceptions about TB. And so once that is done, then people will agree to be screened more. But again, as a stigma strategy, I think one of the best ways is that engaging people, like Deepti said, the survivors who've gone through this stigma before. I think this would be the loudest voice, you know, in terms of helping in this health education, helping in speaking out like I'm doing, like Deepti is doing, so that people understand, yes, you can have TB, get healed, and just live a normal life complete with no complications. And so when you have these living examples being in the front line, the TB survivors and the TB advocates being in the front line, then I think we will see our levels of stigma reduced to very low levels. So indeed, one of the main strategies I would say would be really engaging the TB survivors and the TB advocates as a big cohort of people will help in raising these voices. Yes.
Thank you. I think there's one more question to both of you. What is your opinion about the physician's knowledge about TB as a DSE, the drug resistance? Oh, hang on, disease. Okay, as a disease, as a TB as a disease. and the approach to it. So the physician's knowledge. What is your opinion about what a physician should be knowing about it? I guess that's the question.
Well, this is a clarification. Physician in terms of the specialist physician, or physician in terms of clinicians in total. I think one of the things from my experience is that clinicians, physicians know a lot about TB, but sometimes I don't know, you are afraid, you don't want to disappoint your patient, that you're thinking about TB. So I'll insist on treating pneumonia. You know, you're moving around the circle, but you don't want to go and say it's TB. This is what I say. When I'm seeing my clients, I better think about the bigger elephant in the room and rule it out than assume it's not, and yet that's the cause of the problem. So if you're presenting to me and, like I said, there are those suspicious signs and symptoms of TB, I would rather that we do sputum, screen, and do the test for TB and ensure that it's not TB. Then I can confidently treat you for pneumonia or another chest ailment. So the knowledge is there with the physicians, but I think depending on where they're practicing, especially the private sector. So I'm afraid to discuss this with my patient, because my patient might look at me as maybe less qualified. Why am I thinking my patient is suffering from TB, and I'm healthy nutritionally. I'm from a well-off sort of background, you know. So then they're afraid to make TB the first discussion, and so that for me would be the main point.
That's a very good point. Thank you. I want to thank everyone for asking questions. I want to open the floor. I first want to ask Deepti to comment on the points that David has brought forward. And then I want to open the floor to anyone who wants to make a general comment. Please let me know in the chat function, but then I can unmute you if you want to speak in a general point. We have 10 more minutes. So if there's any more questions or general comments, let me know and you'll get the floor. But first to Deepti.
Okay, so the one question was about what is the one thing that we need to do, and the first thing that comes to my mind, considering the whole India's TB landscape, is we need to increase the funding, because as advocates, when we advocate for, say, a DST for every person diagnosed with TB, or say newer and safer drugs, or maybe nutritional support or economical support, the only argument the people from the program make is that we have budget constraint. We do not have that much money. If we give DST to every patient diagnosed with TB, we'll run out of funds. So I would say that considering how TB is killing millions of people every year, we really need to act. And if we are serious about ending TB, we really need to get our priorities straight. And if budget constraint, like we tend to spend on so many other not so important things. So if for me, I think that people's lives are important, and if we just put in more funding in the TB budget, and I think most of the needs would be then solved.
Very good. Thank you, Deepti. I have two people who have come forward to say something. So I'm gonna first ask Anne, unmuting you, and then Evelyn Kibuchi. I'm both putting you, so first Anne, please go ahead.
Thank you very much, Petra, and thank you for organizing this session. It has been very, very eye-opening, and I'm really glad that people who have been affected by TB have come out to talk about it, because they're the people who are really going to help us to demystify the misconceptions about TB, the stigma around TB, and especially the association of TB with HIV. Just this afternoon, I was telling my sister I have a very important session that I need to participate in. And she told me, I cannot have a TB test because they'll say I have HIV, you know? So really having people who have come out to share their experiences and demystify those misconceptions, and David's experience where he even had HIV done 3 times because the healthcare worker probably thought, no, it has to be associated with HIV, is a big step to help reduce stigma on TB. And if we don't talk about stigma and how to reduce that, then we will not get to, our endpoint of ending TB. And so that is really good. We need to think about other strategies that we need to put in place to really address issues of stigma. I know we talk about stigma, but we have not done enough, I feel, in our programs to really address the issues of stigma. So I'm glad Evelyn Kibuchi is on the floor from Stop TB Partnership Kenya. I'm from Center for Health Solutions Kenya. And I'm glad at least we have a team that will really begin to, we've been talking about stigma, but we need to move to the next level on how to really address stigma if we are to end TB. Private sector engagement, yes, that has been very critical. I know I have done some work on private sector engagement, and I did a review of some facilities a few months ago. Private sector, yes, for some are very green about TB. They still feel TB needs to be addressed by a specialist, but TB can be managed by any clinician at the health facilities. So we really also need to sensitize healthcare workers in the private facilities to really be able to manage TB properly and improve quality of care for patients in the private sector. So thank you very much for this session. I hope we'll look forward to more engagements, especially on private sector engagements. Thank you, and thank you to the presenters. Very, very good session. Thank you.
Thank you, Anne. Evelyn, you now have the floor.
Thank you very much, all the speakers and even the organizer for this. And thank you, Anne, for your comments. I have 2 points on my proposed points on how we can address TB. One, I cannot overemphasize on the issue of stigma. I think what is actually killing people with TB is not even lack of access to diagnostics or treatment or whatever. It's stigma. And I'll give a simple story. I lost a friend who had been living with HIV for about 10 years. She was taking her ARVs comfortably and she was comfortable with HIV, but she got TB, and the moment she felt symptoms that she related to TB, she completely refused to come out of the house. She said, I have lived with HIV, I have been looking very healthy, no one ever suspected that I have HIV. But if I step out with my loss of weight, with my cough, everybody now will think I have HIV. That's how they will know I have HIV. So for that reason, I will not come out of the house. She completely refused to go even for the first test. And that's how she died from TB. To me, it's stigma that killed her. It's not because we didn't have diagnosis in Kenya. It's not because we didn't have treatment. It's because we didn't have facilities. Stigma killed her. Number 2, education, awareness. I come from a country where people own diseases. Someone says, my migraine headache, my malaria, my this, my that. But I'm here to come across somebody who openly says about my TB. And I think we have to create awareness where everybody can be comfortable to own TB, so to speak. I know you don't want to own TB, but where you can openly say that you have TB, walk on the streets and say, I am rushing to the clinics to refill my drugs for tuberculosis. Like, I have added weight since I started taking treatment. Then when you say, I think I have a cold, and you rush to hospital, can we have awareness created in such a way that I can comfortably say, I am going for TB treatment, I'll be back, up to that level. So long as we are not openly talking about it, I'm telling you, we are very, very far from getting to the end. And my last point, investment in communities, especially those ones who are infected and affected with TB. And here's my point. I always think anybody who has hit the frame of a healthcare facility going for TB treatments, there are 90 or more than 90% chances that will get cured. My biggest problem is those ones who have TB, they have symptoms, but they either don't know that they have TB or they don't want to go. Stigma. And who can get those people? It's not the health work, it's not the doctors, it's not the nurses, no. They are the people living, it's the communities living with the rest of the communities. So we need to invest in the communities that are living with the people, so they can support people who are likely to have TB. They can encourage them to go for treatment. They can encourage them to finish treatments. That's to me, it's one of the magic bullets that we are remaining with. And finally, on the private sector, I think, like in Kenya, the private sector is almost always the first point of treatment before they are referred to the public hospitals. So if we do not empower the private sector, if we do not engage them, then we're going to lose so many patients, in between the private sector and before they are referred. So we need to make the private sector like one of the stakeholders that we have to work with to address the TB menace. Thank you.
Thank you so much for your comments. These are really, really useful points, Evelyn. I have a follow-up question actually here in the log that on this to both David and Evelyn, but also Deepti. In your experience, what might be some reservations that the public sector providers might have about engaging the private sector, including traditional or faith healers in TB care? And how can we manage these reservations? So basically, how can we include the private sector stakeholders, despite that some public sector might be a little nervous about this? Does anyone want to speak to that? Yes.
I can give it an attempt.
Okay.
I think the private sector are seen as commercial entities that are out there to make money. And so the public sector feels like once the patients get to the facility, they are looked as a business, like it's a business that has come to me. So I will have to ask for so many tests so I can get more money from the patient before I finally go for TB, which from the first beginning, I thought it was TB, but I will have to go send for a pneumonia test. I don't know, check for sometimes even cancer before I finally say, okay, can we check TB? By then they have milked, so to speak, a lot of money from these patients. So I think these are some of the conceptions or misconceptions that the public have about the private sector. And that's why I feel, we all agree that the private sector are there for business and they survive on money that comes from the patient. So we need to work with them so that, first of all, they need to know what are our targets. What targets are we working towards a TB, so they can own the response, so they can feel proud when they diagnose one patient. When they see one patient from the beginning to the end, they can say, yes, I am one of the people contributing to achieving towards a 2030 target, that I am not just here to make money from the patient, but I'm here to make a difference with my practice. Let's integrate the private sector to owning the TB response, so they know they're making a contribution, not just making money.
Yes, Petra. Yes, totally agree. One of the reservations the public and even the health workers in public always have towards the private sector is that they worry that it will be costly, what Evelyn has correctly alluded to. So you are thinking this patient is better way off in a public sector system than going to the private. And so it will be the issue of delayed diagnosis, additional tests, which eventually are not tests to diagnose TB, but just moving around the whole illness. And then secondly, the perception also from the private sector for a long time, I mean, TB being a public health issue was then always thought to belong to the public sector. So me as a private practitioner, once I'm thinking of TB, then I'll be quick to tell my patient, go to a public facility. So that also needs to change, so that we, like Evelyn said, we own the problem together. This is a problem that's cutting across the board. So if I know that I diagnose this patient, like I explained, and then I'm able to offer management to the end without having an effect on the resources I'm using, then I'm more likely to come on board and prevent this perception that this is a public sector problem, this is a public health problem, I'm not a public health specialist, I'm not the government, so hey, go to the public sector. Yes, so both ways. Thank you.
Thank you, everyone. I'm conscious of the time. It's 9 o'clock, or at 9 o'clock in Ottawa. It's of course a beautiful different hour wherever you are, but it is an hour later. I feel that we've discussed a wealth of topics. I'm really pleased with the depth of the questions that we've had, and this is such an important, so important to have actually both you, Deepti, and David come forward and openly talk about it. We see that many of the issues around stigma and the knowledge, and you have lived through this, you have done an amazing job in explaining to us what your journey was, and we're super happy to have you part of this community to actually be able to voice out on behalf of other people. And there's a clear need, and especially after today, you'll see that you'll be in work for much longer on this issue. So I would like to, I see a few more questions and comments. Let me just quickly review majority of, the majority, okay. Talking about incentives and money and future. I think this is our first webinar. This has been great. There's so many good questions that will come up in the many other themes that we are planning. We have planned out several webinars for 2020. So in January, this third week of January, in the week of the 12th of January, please keep your eyes out. We will be looking at planning a webinar where we start talking about the roadmap that we've outlined on how to engage the private sector. So this will be an introduction session on many of the themes that we talked about today from the TB survivor perspective, but now more from the policy perspective. Both Guy Steiwaldy and Monica Diaz will be talking on that call. Many of the points that were brought forward today are going to be addressed again. We would really like to have you all join. Please also keep a watch out on our website. I will be posting this full session and a summary of what the main points will also be available. You will be able to refer people who have missed this session to our website, tbppm.org. There's also a page with many TB survivor stories where you can find videos from Deepti and many other people that have talked about TB, so you can refer people to that site as well. If you want to download some videos, that's a place where you can find some information. So if you haven't joined our community yet, please do so. We're trying to have discussions on our platform as well. So if you want to interact with anyone, feel free to communicate. There are many ways to talk to each other on the platform, and everyone is welcome. So forward your information to other colleagues if you want to invite them to join. I would like to thank the speakers. Thank you very much for your time. And I wish everyone a good rest of their evening, afternoon, or day. And I'm looking forward to continuing these discussions in 2020. And with that, I think I'm going to close this first webinar. Best wishes to everyone.
Thank you so much for having us. Thank you.
Thank you. Bye-bye.
Bye.